The subcommittee will come to order. We'll now resume with our second panel. Our witnesses for the second panel today are I have to put my glasses on, sorry about that. Dr. Stephen Furr, President-elect of the American Academy of Family Physicians, Dr. Deborah Patt, Executive Vice President of Texas Oncology, Mr. Joe Albanese, Senior Policy Analyst for Paragon Health Institute, and Dr. Matthew Fiedler, the Joseph A. Peckman Senior Fellow in Economic Studies at the Brookings Schaefer Initiative on Health Policy at the Brookings Institute. Dr. Furr, you're recognized for 5 minutes for your opening testimony.
Chairman Guthrie, Vice Chair Dr. Bouchon, Ranking Member Isho, and members of the subcommittee, my name is Stephen Furr. I'm a practicing family physician in Jackson, Alabama. I'm the co-founder of the Family Medical Clinic of Jackson, which is a rural health clinic, and the chief of staff of a small rural hospital and medical director of the local nursing home. As the president-elect of the American Academy of Family Physicians, I'm honored to be here today representing 129,600 physicians and student members of the AAFP. I went into family medicine over 35 years ago as a National Health Service Corps scholar to serve an underserved community. I went there, paid my dues, did my time, and I did what the program meant to do. I stayed there and continued to serve that community. I've stayed there ever since. My training has allowed me to develop long-term relationships with my patients and deliver patient-centered primary care. We're not called family medicine physicians just because we treat the whole family. We're called family medicine physicians because our patients are part of our extended family. Being a rural family physician is incredibly rewarding, but in the last several years, it has gotten much more difficult. My patients have more chronic medical problems that require complex, ongoing care management. More and more, they're looking to our practice to help with their depression and anxiety, meeting basic needs, and navigating an increasingly complex healthcare system. But instead of providing primary care practices with support to meet these growing patient needs, we're left struggling to stay afloat as payments shrink and administrative requirements multiply. Our failure to invest in primary care is being felt across the country in patient outcomes and repeated challenges trying to find a primary care physician. Data released just this week shows that over 16,000 primary care physicians have left the workforce over the past year. But as a country, we've never needed primary care more than we do today. Despite much higher spending per person, the U.S. spends less on primary care, has the highest rates of people with chronic conditions, the lowest life expectancy, and highest preventable death rates compared to our peer countries. Primary care leads to better population health, more equitable outcomes, and lower mortality rates. In other words, primary care is uniquely suited to help address the pressing healthcare problems we face today. I'm pleased to see the subcommittee's attention on ways to better support patients and physicians with appropriate payment for the comprehensive patient-centered work we do and a tangible reduction in administrative workload. We're encouraged by steps Medicare has taken to more appropriately value physician office visits. In 2024, CMS has proposed another incremental step to better value primary care. The G2211 add-on code would better account for the time, resources, and expertise involved with providing comprehensive primary care. Primary care office visits are more complex, and G2211 is intended to recognize that. Opportunities to meaningfully invest in primary care under our current system are rare, but this is one of the few of them that we can use. I urge Congress to support implementation of this code. However, coding and billing challenges alone won't fix the broken physician Medicare payment system. We need congressional action. I strongly urge Congress to reform budget neutrality requirements, enact an annual inflationary update for physician payments, support physician practices moving into value-based payment models, and pass the Lower Cost, More Transparency Act. But strengthening Medicare for patients goes beyond just improving payment. Congress must address administrative burden, which has become totally unmanageable. My staff and I spend hours every day navigating prior authorization and step therapy requirements that prevent patients from being able to access evidence-based treatment in a timely manner. Thankfully, the subcommittee has the opportunity to address some of these issues by first passing the Improving Seniors Timely Access to Care Act, reforming step therapy in Medicare and Medicaid, requiring Medicare Part B coverage of all recommended vaccines so that we can give all vaccines in our office and then not have to go to the pharmacy for that, standardizing quality measures across payers and programs. Primary care in this country is at a tipping point, but Congress can help to change that. Improving payment and reducing administrative burden will not only be an investment in primary care, but also in our patients and your constituents. Thank you for the opportunity to provide this testimony. I look forward to trying to answer your questions.
Thank you for your testimony. Dr. Pat, you're recognized for 5 minutes for your testimony. I think your mic, you probably have to hit the mic button.
Chairman Bouchon, Ranking Member Eshoo, and members of the Health Subcommittee, I appreciate the opportunity to testify on this extremely important hearing on the prognosis of medical care in America. My name is Dr. Deborah Patt, and I've spent the past 17 years seeing and treating breast cancer patients in Austin, Texas at Texas Oncology, a large physician-owned private practice in the great state of Texas. I also serve as an executive vice president of Texas Oncology and a vice president and board member of the Community Oncology Alliance. As you consider policies in today's hearing, I want you to envision the consequences of inaction. Continued Medicare fee schedule payment cuts pose real and serious threats to Medicare beneficiaries accessing medical care. Decreasing reimbursement causes a chain reaction that results in provider network inadequacy, decreased access to care, inability to manage staffing shortages, and decreased quality of care for Medicare beneficiaries. The disproportionate burden felt by non-hospital affiliated practices like mine, the disparity in reimbursement is fueling consolidation into hospital systems that are driving up the cost of medical care for all Americans. We face continued cuts in Medicare reimbursement. Since 2014, medical inflation has increased substantially every year, yet Medicare reimbursement, as measured by the conversion factor, has only decreased. The ever-widening gap between the inflation rate and Medicare payment can be seen in the graph included in my written testimony. It shows medical inflation has risen by 28.4%, while the conversion factor has had a 5.4% decrease since 2014. We have issues of network adequacy, quality of care, and physician burnout. CMS is constantly cutting Medicare reimbursement for physicians, has the natural consequences that harm Medicare beneficiaries as it results in decreased access to care through network inadequacy. I frequently have breast cancer patients in my clinic that I have to juggle and ask favors to get them to be seen by a primary care physician or another subspecialist, so I have to use my time. I have to refill their primary care medications, and they frequently have gaps in care where no one is refilling their medications, and they go without their diabetes or their hypertension medications. This causes care fragmentation, delays, and detours in appropriate care. The pressures on independent physicians today is leading to increased physician burnout. According to a recent study, over 145,000 healthcare practitioners left the healthcare industry from 2020 through 2021, threatening access to medical care. 71,000 of these were physicians. This is alarming. We face staffing shortages. This burden of declining reimbursement has been exacerbated by a national crisis and shortages in healthcare staffing. Just last week, you might have seen the announcement by Kaiser Permanente that after a 3-day strike, they reached a negotiated deal to increase payments by 21% over 5 years. As a physician in private practice facing decreased cuts, only challenged further by inflation, how would I pay for increases in staffing to continue to staff my clinics and be competitive? The natural consequence of this is breast cancer patients aren't able to get mammography. Cancer infusion centers and radiation facilities aren't able to open to capacity because we have staffing shortages. We're on the verge of a major crisis in medical care, and we best just fiddling as Rome burns. Inaction will lead to further consolidation and increased healthcare costs. Independent physician reimbursement cuts adversely impact the entire healthcare ecosystem. However, because hospital systems receive an annual Medicare inflation adjustment, the physicians in private practice do not, and the ever-widening gap between independent physicians and hospital reimbursement is contributing to consolidation of medical care into the more expensive hospital setting. This is especially true with 340B hospitals, as a study of the top 340B hospitals showed that some markup cancer drugs are unbelievable at 5 times, meaning if you have a cancer drug that costs the hospital $5,000, it can be marked up to $25,000. In addition, by ignoring hospital survey data, CMS is overpaying 340B hospitals by close to 50%, contributing to a 6% premium increase for Medicare beneficiaries that they will pay in 2024. We need to pass meaningful legislation. I want to underscore that it's critical at this time for Congress to fix the looming Medicare payment cut, as well as provide independent physicians with a much-needed medical inflation update. Congress needs to make payments equitable in the hospital and private practice settings by passing site neutrality legislation and fixes to a broken 340B payment system. Additionally, Congress needs to address abuses by insurers and their PBMs, including excessive prior authorizations that hinder quality and timely cancer care. As a doctor in private practice, we need you to consider this legislation and make meaningful change to improve the prognosis of medical care for Americans. Inaction will fuel the chain reaction resulting in burnout, shortages, network inadequacy, and a fragmented and disrupted medical care for Medicare beneficiaries. We need you to act now to improve the prognosis of the American healthcare system. Thank you for your time, and I'm happy to take any questions.
Thank you for your testimony. Mr. Albanese, did I pronounce that correctly?
Yes, thank you.
All right, you're recognized for 5 minutes for your testimony.
Vice Chair Bouchon, Ranking Member Eshoo, and members of the subcommittee, my name is Joe Albanese, and I am a Senior Policy Analyst at Paragon Health Institute, a think tank dedicated to empowering patients and reforming government programs. I want to thank you for inviting me here today to discuss how to improve payment policy in Medicare. My testimony today reflects my own views. Medicare payment policy should reflect 3 key goals. First, maintaining access to care. Second, minimizing costs. And third, improving payment accuracy. We should all be committed to securing seniors access to health care. Fortunately, 98% of physicians accept Medicare rates, and this percentage has increased over time. However, policies that increase administrative burden or underestimate physician pay could undermine this. Congress must also be cognizant of the fact that Medicare is on an unsustainable trajectory and should reduce long-term cost growth. These costs fall directly onto the shoulders of beneficiaries through cost sharing and premiums. Just last week, CMS announced that Part B premiums will increase by roughly 6% next year due to rising Medicare spending. On average, seniors already spend about 28% of their Social Security checks on expenses in Parts B and D alone. The fiscal sustainability of Medicare itself is also crucial. Part B, which covers physician services, is the fastest growing part of Medicare. The Medicare trustees project that this trust fund, which is mostly financed by general revenues, will consume over 1/5 of federal income tax revenue by the end of the decade. Rising costs will directly contribute to deficits, which may result in painful benefit cuts, tax increases, or economic harm to families in the future. Finally, Medicare payment policy directly distorts decisions in the healthcare sector. Fee-for-service payment encourages a higher volume of healthcare procedures regardless of their quality. Administrative price setting by government agencies is limited by data availability and bureaucratic decision-making processes, which do not reflect the true value of a service. Both Congress and CMS have historically struggled balancing these 3 goals with Medicare payment policies. Under MACRA and the sustainable growth rate before that, the per-unit price of physician services stagnated, which helped to control overall spending. However, the volume and intensity of such services on a per-enrollee basis rose, and Part B spending still grew in other areas. Furthermore, maintaining lower payment rates may compromise long-term participation by doctors. So far, data from CMS and MedPAC have found that access to physician services is stable or improving. However, Congress could enact policies that would improve Medicare payment policy on these dimensions for both beneficiaries and taxpayers. First, Congress should offset any physician payment increases with other Part B savings. Spending on outpatient hospital services, Part B drugs, and other areas has grown rapidly. Common sense policies like site-neutral payments or reducing statutory overpayments on drugs can save hundreds of billions of dollars without making any changes to seniors' benefits. Second, Congress should adopt more market-based pricing for doctors. The current process leads to observable errors in payment rates for certain services, and disparities between specialties have reduced the supply of primary care practitioners. Simply increasing pay by inflation will not address these issues. Market competition is a more efficient way to determine the economic value of a service. So gradual improvement is possible by tying Medicare payment policy to rates negotiated by Medicare Advantage plans. Third, Congress should eliminate quality payment programs like MIPS and the financial incentives for advanced APM participation. These policies have been the clearest failure of MACRA and have been responsible for increasing clinician burden without improving value. A recent CBO report has reaffirmed that APMs have lost money for Medicare instead of saving money. Government experimentation and micromanagement in healthcare delivery is not a path to success, and it does not make sense to subsidize participation in models that do not work. Ultimately, quality metrics are best when they enable seniors to make informed choices between coverage and care options. This is already possible in Medicare Advantage, which has become increasingly popular in recent years. Policymakers should ensure that it remains a viable option for seniors and encourage participation between MA and fee-for-service. Balancing policy goals is a difficult task, but removing government distortions rather than adding new ones would be a much more effective way of maintaining access to care, containing costs, and improving payment accuracy. Thank you, and I look forward to answering your questions.
Thank you for your testimony. I now recognize Dr. Fiedler for 5 minutes for your testimony.
Vice Chair Bouchon, Ranking Member Eshoo, and members of the subcommittee, my name is Matthew Fiedler, and I'm a health economist and a senior fellow at the Brookings Institution. I'm grateful for the chance to appear before you today to discuss ways to improve how Medicare pays physicians. I want to begin by discussing the trade-offs involved in deciding how much Medicare pays physicians. Broadly, policy must balance two objectives. The first is ensuring that Medicare beneficiaries can access high-quality physician care. The second is limiting the costs that higher payment rates impose on taxpayers, who bear higher program costs, on beneficiaries, who bear Medicare premiums and cost sharing, and even on the privately insured, who research finds pay more for physician care when Medicare pays more. Data on how well Medicare beneficiaries are able to access physician care can help guide policymakers as they work to balance access and cost. In that vein, I want to highlight two facts. First, survey data show that most Medicare beneficiaries do not currently report major problems accessing physician care. In 2022, around 4/5 of beneficiaries who searched for a new primary care provider said they either had no problem or only a small problem finding one. About 9 in 10 who sought a new specialist said the same thing. Similarly, about 2/3 of beneficiaries who sought care for an illness or injury reported never waiting longer than they wanted to get an appointment, and more than half said the same for routine care. And along all of these dimensions, Medicare beneficiaries report comparable or slightly better access to physician care than the privately insured. Second, Medicare beneficiaries' access to physician care has remained relatively stable even over a 2-decade period in which practices' input costs have grown faster than Medicare's physician payment rates. This could indicate that changes in Medicare payments currently only have a modest effect on access, or alternatively, that other changes in the delivery system, like greater reliance on non-physician professionals, are offsetting slow growth in physician payment rates. Looking ahead, it is possible that the delivery system might respond differently to future payment changes than it did to past ones, perhaps especially if input costs outpace payment rates indefinitely. Additionally, under current law, input costs will likely outpace payment rates by more during the next year or two than they did during the typical year in the past 2 decades. The data I'm speaking to here also don't address trends in outcomes other than access, like quality. Nevertheless, this recent history does suggest that there is some scope for Medicare's physician payment rates to grow more slowly than input costs in the years to come without a decline in access. In the time I have left, I want to briefly highlight 4 structural changes to how Medicare pays physicians that are worth considering regardless of what policymakers decide about the level of payments. The first is eliminating the merit-based incentive payment system, or MIPS, which evidence suggests is failing at its goal of improving the quality and efficiency of patient care, but is creating large compliance costs for clinicians. Since eliminating MIPS would make it cheaper for clinicians to treat Medicare beneficiaries, it could be a low-cost way of addressing concerns that Medicare's physician payment rates are inadequate. The second is maintaining bonuses for participation in advanced alternative payment models, or APMs, rather than allowing these bonuses to decline sharply as scheduled under current law. In contrast to MIPS, well-designed APMs do appear to improve the efficiency of patient care, and the current payment bonus both encourages these models' uptake and gives CMS flexibility to improve their design. The third is insulating future physician payment rates from inflation shocks, but in a budget-neutral way. Physician payment updates are currently fixed in law, so shocks to economy-wide inflation can cause inflation-adjusted payment rates to be higher or lower than currently expected. This could be avoided without a large scored cost by specifying that payment updates should equal the Medicare Economic Index minus an appropriate fixed percentage. The fourth, which takes me beyond physician payment per se, is adopting site-neutral payment for ambulatory services, as this subcommittee has considered at other points this year. The benefits of site-neutral payment in terms of reducing costs in the Medicare program and beneficiaries and removing incentives for consolidation are likely familiar, so I will not repeat them. But I will note that site-of-service payment differences will likely grow over time if Medicare's physician payment rates continue to grow slowly in the years to come, which will magnify the importance of shifting to site-neutral payment. Thank you again for the opportunity to testify. I look forward to your questions.